Welcome, everybody. I'm Nona Baker, co-chair of MPN Voice, and I'd love to welcome you all, especially those from Canada, America, Budapest, Ireland, and all the people from the UK as well, to the MPN Voice virtual forum today. Just a little bit of housekeeping. There's still a chance to submit your questions to the panel. Please use the Q&A box to send your questions at any time during the event, and we will do our very best to answer as many as possible. Just a heads up here, we cannot answer any questions about your personalized treatment plans. Please speak to your consultant. And also please use the Q&A box for questions you would like our panel to answer, not the chat. And one thing I could ask a big favor of you all, please could you fill out the feedback survey? It's really important to us at MPN Voice to shape the things that we do to meet the needs of the community. And just briefly, because some of you are new to our virtual forums, I'd just like to spend just a little bit of time talking about MPN Voice. We started in 2004 basically to serve the MPN community, which is patients and healthcare professionals and patients' families. And it was started on the basis that there wasn't a lot of very accurate information around. And it became, as more and more people were diagnosed, it became really important to make sure that we provided accurate information and up-to-date information, all of which is medically verified. In supporting patients and their families, the up-to-date website, and I really recommend you look at it, www.mpnvoice.org.uk. It is constantly being updated, and you will find out as much information as possible or links to other information by clicking on that. The forums, well, here we are at a virtual forum. Those have had to be virtual because of the dreaded COVID, but I can say that luckily, and this is particular to all of you in Ireland, we're doing our first face-to-face in 2 weeks' time on the 21st of May in Cork. So if you haven't booked on, please feel free to contact Maz and book on as soon as possible. There are some places still there. Online support has been key, and we do that through Health Unlocked, our YouTube channel, Twitter, Facebook, Instagram, and just recently, because we've been missing the face-to-face contact with patients, I've started a monthly vlogcast talking to members of the MPN community. There's also a young patient who is doing MPN blogs. All that information will be on the website. A lot of hospitals have Cns Led Support Groups, and it is worth asking your local haematologist where and if there is a Cns Led Support Group in your area. Buddies, this is key. I was diagnosed in 1991 with ET, and my goodness me, it would have been lovely if there was a buddy around then. What we do is, if anybody is struggling with the diagnosis and particularly coming to terms with the word cancer, we can connect you with people who've been there, been through the emotional turmoil, and connect you with somebody who can basically hold your hand through the beginning of the journey of having an MPN. Advocacy. Having a global patient voice in decision-making processes has become really important. This includes pharma and government bodies in the decision-making process for drug approval and availability. And I know that's different in each part of the United Kingdom, and certainly different for those of you watching from America and Canada and other parts of the world. We have printed information booklets and resources. So if you feel you need to, you're not very au fait with the internet or the website, or know somebody that isn't, do contact Maz at info@mpnvoice.org, and she can send you some leaflets. We also do a lot of fundraising for funding of research projects. I mean, most patients actually will be the first to say, why have I got it? Or what, is there ever going to be a cure? One of the biggest things that we're funding at the moment is the Mosaic study, an epidemiology study, which is ongoing to explore some of these issues. And on that basis, I have one plea. In order to be able to do all this, we are really dependent on donations, and those donations enable us to continue the work that we do. You can donate via the MPN Voice Just Giving page, the justgiving.com /MPN Voice, or you can donate using the QR code. And any queries, again, please contact Maz at info@mpnvoice.org.uk. Thank you for joining us. I'm sure this is going to be a really helpful forum, and I'm delighted to welcome Claire Harrison, who is going to take the lead now and introduce all these wonderful clinicians who are giving up their time for us. Over to you, Claire.
Thanks very much, Nona. Hello, everyone. I'm Claire Harrison. I work at Guy's Hospital, but just now I'm lucky enough to be stationed on the very sunny West Suffolk coast. So any of you who are down here and enjoying lovely weather, that's fantastic. So this is actually one of a series of new forums that we're going to be putting out covering specific topics. And today's plan is we've got 3 fantastic speakers who are going to cover aspects of, for example, what's in a blood count, how do we make a diagnosis of MPN? And then we're going to look at bone marrow biopsies. Many of you will have had one of those. And maybe you're wincing right now thinking about that, but having a look at what they look like and why we use them for diagnosis. And then we're going to peer into the future and think about how we are going to be and are currently using artificial intelligence to interrogate this data. So please do ask questions. Please do make this interactive. I am sitting here with a spreadsheet of questions that have already come in. We'll try to respond to all of your questions and those that you've already submitted, and do give us feedback. So we prioritise this session based on feedback from our last focus forum, which was on COVID and COVID treatments. So this is the agenda. So you've already had a welcome from Nona and myself, and shortly I'm going to hand over to Andrew McGregor, who's a consultant haematologist in Newcastle, and he's going to talk to us about blood cells and blood counts. And then we've got a section on diagnostics and bone marrows from Anna Green, who is one of the consultant haematopathologists. That means she's a specialist pathologist in haematology, who works at Guy's and St Thomas's, and Dan Royston, who does a similar job at the John Radcliffe in Oxford. So they're going to do a joint presentation, and then we will have a question and answer session, and followed by that will be a wrap up from Nona and myself. So without any further ado then, Andrew, are you ready to have a go at the technology?
I hope so, yes. I'm going to share my screen now.
So just to say welcome and thanks so very much for giving up part of this sunny Friday afternoon. Yeah, I see your slides.
So can you see my slides now? Does that look all right?
Yes, but they're in a funny format. So they're showing the current slide and the next slide. Are you maybe using multiple screens?
I am, yes.
Andrew, if you just click on display settings at the top of your screen, there, and then there should be an option to swap the top one. Yeah.
Has that worked?
Perfect. There you go.
I should have had you yesterday when I was doing a presentation and I couldn't work out how to do that. So so I now know that's really useful. I've learned
some learning for all of us. Yeah.
Yes. Yes.
Thanks, Andrew.
Thanks. So my name's Andrew McGregor. I'm a haematology consultant at Newcastle. So I'm going to cover the blood count, what is in blood, and some of the changes in the numbers and what some of the cells look like in patients with myeloproliferative neoplasms, and some of the pitfalls that I come across from a day-to-day life of working as a haematologist and working with patients with myeloproliferative neoplasms and in the interpretation of the blood counts. So this session is based around a case. So Fiona is a 70-year-old woman who comes originally to her GP surgery for a routine health check. And she had a full blood count done because of that. And it is noted that her platelet count is elevated. So over the course of this talk, we're going to see what happens to Fiona, but I thought we would start with where the blood is made. And we talk about blood and bone marrow, and how I explain it is that the bone marrow is the factory that makes all of the blood cells. The bone marrow is all over the body, but most of the blood is made in the pelvis and in the long bones and in the sternum, but mostly in the pelvis. But it is made inside all of the bones. In adults, before we are born, it's made in the liver and the spleen. And that's important because sometimes when the bone marrow struggles to make enough blood cells, that function of the spleen making some blood cells can return. And that's one of the reasons why some people with myeloproliferative neoplasms can sometimes get an enlarged spleen, because that starts to think the bone marrow is maybe struggling a little bit, or the spleen gets a bit excited and starts to want to make blood cells again. So what is in the blood? Obviously, when you have blood taken, it all just looks like red liquid. But when it gets to the lab, it gets spun down in a machine, and then that enables the blood to be separated out. So we've got the plasma at the top. The plasma contains lots of things such as proteins, things that help us fight infection. Then in the middle, the small little orangish band in the middle contains the white cells and the platelets. And then the bottom bit is the red cells. So we'll take these in turn. And this is what the blood looks like under the microscope when we look at it. You will see that there's a white cell at the top right-hand corner. And then you will see that most of the cells here are actually red cells. And then hopefully you'll see in between the red cells are these tiny little purple dots, which are the platelets. So so that's what we look. That's a normal blood film when we look at it under the microscope. And I should say that many of you may know this, or many of you may not know this, but hematology is quite a unique specialty in medicine, because we are not only trained to look after patients and see patients and examine them and prescribe treatments, which a lot of my day is spent doing, but we're also trained to go to the lab, make sure the lab is functioning properly, and look at the blood and the bone marrow under the microscope. So it gives us that unique aspect of patient care, that I can see a patient in my clinic, I can take a blood test, I can take it to the lab and then look at it under the microscope. And actually in most labs, it doesn't take that long to get to look at the blood film under the microscope. Most of us have got sort of quick stainers, so we can look at it under the microscope pretty quickly if we really want to. So the red cells make up most of the cells in the blood, and each day the bone marrow makes many cells. I don't even know what that number is, but it's a lot of red cells. The red cells can last for up to 3 months in the blood. And the red cells contain hemoglobin. Hemoglobin is the molecule that helps carry oxygen around the body. So you'll breathe in, the oxygen will go into your lungs. Then the red cells will grab a hold of it and take it around your body, so your body is nourished with oxygen. And then similarly, the red cells help take some of the waste products back. So it helps take carbon dioxide back to the lungs, where you will breathe it out. Hematocrit is another way to tell how many red cells that you've got. So we use hemoglobin and hematocrit, but they both give a similar sort of aspect of how many red cells that you've got. So a lot of us will know what anemia is. Anemia is not enough hemoglobin. Commonly that's due to bleeding, or if you've got iron deficiency, or if the bone marrow isn't working properly, and that can happen with some people with myeloproliferative neoplasms. But if you've got too many red cells, that's called polycythemia. And again, obviously that will happen in some people with myeloproliferative neoplasms. Polycythemia usually is not due to a myeloproliferative neoplasm. Polycythemia in most of our practice is due to other causes, like if you haven't got enough oxygen, so you've got lung disease and you haven't got enough oxygen, so the bone marrow will think, I want to make some more red cells to help get that oxygen around the body. Smokers can get polycythemia. You can get polycythemia if you're dehydrated. But obviously the thing that we're going to be talking most about today is Polycythemia Vera, which is the underlying bone marrow problem where the bone marrow goes into overdrive and starts to make too many red cells without an obvious cause. But like I say, most of the time when we see polycythemia, actually it's not due to a myeloproliferative neoplasm, it's due to other things. And part of our job is to work out why, you know, whether it is polycythemia vera or whether it's the secondary polycythemias, because that involves a different management plan. The other thing that I think it's useful to note, and a lot of you will be familiar with this when you see your blood test results, is that the size of the red cells can change depending on various factors. So the size of the red cells is often reduced in things like iron deficiency or in thalassemia, or it can be high if people have got certain vitamin deficiencies, if they drink too much alcohol, or if they've got liver disease. One of the most important things that I get a lot of letters about from other doctors in the hospital and from some GPs is I'm worried about your patient. Their red cells are very big, and one of the things to note is that hydroxycarbamide universally almost always will make the red cells too big, and that's just a part and parcel of being on hydroxycarbamide. It's not harmful to have large red cells. It's just a known effect of the drug. So if a doctor turns around and says, oh, your red cells are quite big, you can tell them that is almost certainly due to the hydroxycarbamide and nothing to worry about. I did have a patient a couple of weeks ago that was getting lots of blood tests with their GP because they were worried about the size of the red cells, until I said, no, stop doing all this monitoring because we know why the red cells are enlarged. It's nothing to worry about. So the other thing in the blood that we look at are the platelets. The body makes around about 1 million platelets per second. Platelets are involved with blood clotting, and platelets last for around about a week in the blood, so they don't last as long as red cells. Too many platelets is called thrombocythemia or thrombocytosis. Both mean the same thing. And again, most of the time when we see a high platelet count coming through the lab, it's due to secondary problems. So it's secondary to having an infection or having inflammation. People that are bleeding will often have a high platelet count because the body wants to stop the bleeding and the bone marrow makes more platelets. But obviously, we do worry about people with myeloproliferative neoplasms because that can be another cause of having a high platelet count. And the last thing in the blood that we think about are the white cells. The white cells are mostly there to fight infections, and there are a number of different white cells in the blood. Most of the white cells are neutrophils. They help fight bacterial infections. Then we've got lymphocytes, which mainly help fight viral infections. And then we've got eosinophils, which are my favorite blood cell because they're an orangey color, and they help fight various infections, including parasites. Monocytes and basophils are less common in the blood, but we do see them. And part of our job is to look down the microscope and to work out what is wrong with patients. And so we use our microscope skills and looking at the numbers of the blood count to work out what's wrong with patients. This is a patient with sickle cell anemia. The red cells are quite misshapen. This is a patient with iron deficiency anemia, and the red cells are a lot more pale than normal. And sadly, we do diagnose leukemia by looking at the blood down the microscope, and the cell to the right-hand side is a leukemia cell. And occasionally we'll pick up things that are unexpected. This is a malaria infection, which is what we looked at the blood under the microscope to diagnose malaria. So this is someone who's come back from Africa that didn't take malaria prophylaxis. And this is a patient with essential thrombocythemia. So hopefully you will see that you've got the red cells there, but also the purple platelets in the background are increased, and there's a variety of sizes. There's some small ones and there's some larger ones. And this is what we see in patients with essential thrombocythemia. And This is a blood film from a patient with myelofibrosis, and often in myelofibrosis, the red cells, instead of being nice and round, end up changing shape. And hopefully in the middle, you'll see some of the misshapen red cells. And we call these red cells teardrop cells because they look a bit like a teardrop. And in patients with myelofibrosis, the bone marrow often becomes a little bit more scarred. And the red cells struggle to get out of the bone marrow, and that causes the misshapen red cells. So they end up being these teardrop red cells. So that's something that we'll look at down the microscope to see if we think someone has myelofibrosis. So back to our case. Fiona has her blood count repeated and the platelets are still high. And actually she's now become anemic. We've thought about all of the secondary causes and we can't find one. And the GP then contacts a haematologist for advice. And the haematologist says, we probably just need to see this patient in clinic to review them. So Fiona sees a haematologist and she actually reports some weight loss. And the haematology doctor is able to feel the spleen when they examine their abdomen. Now, we've all got, well, all of us should have a spleen. Sometimes they are removed for a variety of reasons, but normally you can't feel it, or maybe you can just feel it in people that are very thin. But this haematologist is able to quite easily feel the spleen when they examine them. The next step is, because the haematologist, because they've looked down the blood at the microscope, they're worried about a myeloproliferative neoplasm. And the next step normally is to look for some of these genetic changes, these variants in 3 typical genes. Now, I think what's important to note is that everyone thinks about, when they hear the word genetics, they think this is something I was born with, this is something I can pass on to my children. In myeloproliferative neoplasms, if people have a genetic mutation, this is something they've developed later in life. So this is not something you can pass on to your children. This is not something that your relatives generally have, but this is something you develop later in life. And this is a blood test that we'll use to see if someone has a myeloproliferative neoplasm. So most of the time with myeloproliferative neoplasms, people will have a mutation in one of these 3 genes. Sometimes people don't have a mutation in either of them, but most of the time it's in one of these 3 genes. The next step is perhaps thinking about a bone marrow biopsy. Now, I know there's already been questions about bone marrow biopsies. We sometimes do a bone marrow biopsy diagnosis. We don't always do that. And that really depends on how the patient is presenting. It depends on the individual haematologist. And it depends on what the blood cells look like down the microscope. A lot of the guidelines that we use to determine whether a bone marrow biopsy is necessary hail from when we didn't have reliable molecular testing, so those genes that I've just talked about. So now we're becoming more comfortable about the genetic changes. Sometimes we think we have to ask ourselves whether a bone marrow is going to change exactly what we do with the patient, because for those of you that have had a bone marrow biopsy, it's not often the most pleasant thing to have done. So in my clinical practice, I sometimes think, is a bone marrow biopsy in this particular patient going to change what we do? And sometimes I discuss that with the patient, and sometimes the patient's keen to know, and sometimes the patient isn't keen to know. And I will have a look at the blood under the microscope, and I will look at examine them and look at their blood cell count, and I will use that to make a decision. Sometimes we will do a bone marrow biopsy later on, when we're monitoring patients, if things change, if the patient's symptoms change, if the blood counts change, or if the blood changes under the microscope. So really, it's up to the individual patient and doctor that often makes that decision. And even sometimes after a bone marrow biopsy, sometimes it's not possible to categorize someone into this neat category of the myeloproliferative neoplasms. Sometimes when we look at the bone marrow under the microscope, we can tell that someone's got a myeloproliferative neoplasm, but we may not be able to tell exactly which one. And Anna and Dan will talk a bit more about that as we go on throughout the afternoon and evening. So if a bone marrow is done, then that will normally be done by a haematology doctor or a haematology nurse. We usually use the back of the pelvis, and we will put a needle in the back of the pelvis after that area has been cleaned nicely, so it's sterile. After the patient has normally had a local anesthetic, so some numbing agent to go into the skin around the area to help numb the area, to help make the procedure less painful. And then usually, certainly where I work, is that we'll then take some of the liquid bone marrow, because inside of the bone marrow, people think it's often a solid lump. Actually, no, there's a lot of liquid inside the bone marrow, and we'll spread that liquid onto a slide at the patient at the bedside. And this is what it looks like when we make the slides, and then we'll take that to the lab, and that will be stained using a chemical stain, so we can then look at it under the microscope. This is what the bone marrow aspirate, so this is the liquid bone marrow, looks like under the microscope. So we get these particles of bone marrow when we look at low power. And then when we look at high power, we can see all of the blood cells, which you can see there. So this gives us a lot more detail than what just looking at the blood. This gives us detail about what the bone marrow looks like and what the cells look like inside the bone marrow. As well as looking at the liquid bone marrow, we also look at a core of bone marrow, or the bone marrow tissue, and this is what Anna will mainly talk about. But again, this involves putting a needle inside the bone, usually a slightly different type of needle, and it's usually done exactly the same time as the liquid is taken away. And this is what it looks like when it comes out of the patient, so normally a couple of centimeters long, and then we put that into a tube, into a plastic pot, and then when we look at it down the microscope, this is what it looks like. Anna will go through that process in a little bit more detail than I have done, but this is one of my favorite parts of my job, that I can see a patient, I can examine them, see if they've got a big spleen or a big liver, I can look at their blood down the microscope, I can then do the bone marrow, I can look at the liquid, I can look at the bone marrow trophine, which is the core of bone marrow, and then I can go back to the patient and determine what the best course of action is once I've told them what I think the diagnosis is. As well as looking at the blood and bone marrow down the microscope, we also look at various genetic tests, and these are all the chromosomes that people have. So this is a female, because they've got 2 X chromosomes. And I have to admit, I don't do this analysis because this is far too complicated for me, but we've got lots of skilled genetic scientists that will look at all of the chromosomes and determine what they look like, and also do a variety of molecular testing, like the JAK2 test, the MPL test, the calreticulin gene test that I've talked about already. So it's not just hematologists and pathologists and that will be doing all the work. Most of the work is done a lot by our scientists in the lab in the background that are really critical for the diagnosis of patients with myeloproliferative neoplasms and the monitoring of patients with myeloproliferative neoplasms. Really, we couldn't do without our scientists in the lab that do so much work to help you that you may not be aware of. So lastly, I just want to talk about some pitfalls in interpreting blood test results. Patients often do have access to their blood test results. And this is the things that I do when I'm reviewing test results. But if suddenly there's an unexpected result, then often you need to repeat it before we jump to conclusions, because sometimes factors that are beyond our control will change the blood, will change what the blood looks like. So for example, if the blood was difficult to get out of a patient, or it's clotted by the time it gets to the lab, then that can give slightly odd results. So it's important to repeat it if we find an abnormality that we're unexpecting. It's also important to look at the trend of the blood cells. It's actually quite common for results like platelets to go up and down. So I don't tend to jump to change much if I get a one-off high result, if the results have been normal. Otherwise, I tend to try and repeat it in the first instance. And also, a lot of my patients become concerned because if their platelet count has went from, for example, 200 to 250, and they think that they're worried about that because the platelet count's increased, but actually that's still within the normal range. And we often find that the platelet count and the red cells will go up and down quite frequently. And as long as it's going up and down within the range, we're not normally too worried about that. So minor changes, we don't tend to worry too much about. Obviously, if the blood tests are persistently abnormal without a clear cause, then that does need further investigation, either from the hematologist or if the patient's still in the care of their GP. And like I say, one of my favorite bits is seeing the patient and looking at the blood down the microscope, because I can get a real feel for what's going on. So going back to our case of Fiona, so she has her blood film and her bone marrow aspirate looked at. Her trophine biopsy are also reviewed, and we look at that in one of our pathology consensus meetings, along with all of the genetic tests, and we marry everything together and try to come up with a diagnosis. That case is then discussed at one of our multidisciplinary team meetings, so an MDT, and that's where we have haematologists, histopathologists, X-ray doctors, nurses, and scientists all in one meeting to make sure we're getting the diagnosis and the management plan right. And then the haematologist or the haematology nurse will go back to the patient, tell them what we think the diagnosis is, and then jointly decide on a management plan. So that's what happened with Fiona. We looked at all the material, and then I went back to her in the clinic and discussed with her and her family what we thought the best way forward was, and gave us some options of treatment, and we made a joint decision moving forward. So that is the end of my talk, and so I'll go back to Claire. Thank you.
Claire, you're just on mute.
Well, I'm sure everyone can lip read. Because the comment was that was a fantastic talk. Thank you very much. Thanks, Danny. So now we're going to focus in on the bone marrow, and over to you, Anna.
Thank you so much.
Just while you're sharing your slides, just to introduce Anna to everyone again. Anna is a consultant hematopathologist at Guy's and St Thomas's, and here's a picture of St Thomas's. Over to you, Anna.
Thank you so much, Claire, and thank you so much to MPN Voice for inviting me to talk this evening. It's a privilege to be able to talk to you all. I just want to check, can you see my slides?
Yes.
Okay, and you can't see. I'm trying to get rid of pictures of me at the bottom.
There's no funny version of it being projected.
Great.
It all looks fine, thanks.
Fantastic. Okay, so I'm now going to move on in the patient's pathway to talk a bit more detail about the bone marrow trophine biopsy. So I'll talk a little bit about how we turn those trophine biopsies into slides. Then I'll talk about what the normal bone marrow looks like, how it changes in patients with myeloproliferative neoplasms, and then briefly about some of the dilemmas that we have as pathologists. So Andrew mentioned about the start of the bone marrow trophine pathway, but in a little bit more detail. After the bone marrow is taken, first of all, we have to put it in a liquid called formalin, which essentially preserves the tissue. And it stays in there for about 24 hours. And then because it's been taken from bone, it's very, very hard and we can't examine it. We have to then put it in a different liquid to soften the tissue to allow us to cut it in the laboratory. So that takes about another 48 hours. And after that time, we end up with a core of tissue looking like this, about 2 centimeters long. It then goes into our big machines in the laboratory, and at the end of this we put the core of tissue or the bone marrow trophine into some paraffin wax. This allows us to cut really, really thin slithers off the surface of the trophine, which we then put onto glass slides. When we first put them onto glass slides, you can't really see the tissue. It's so thin, it's about 1 to 2 microns thick. And you can see the trophine here, but it's pretty much clear. So we have to make it visible down the microscope, and then we add some staining. So if a patient has a bone marrow biopsy on a Monday, by a Friday, we should have this stained slide. And in fact, up until this point, all of this process has been done by my colleagues in the laboratory who are biomedical scientists. And as a pathologist, I'll receive the slide on about day 5, and then I'll start my process of looking at it down the microscope and hopefully reaching a diagnosis. So as pathologists, we like colourful things, and particularly pink, purple, and occasionally brownish cells. So normally when we stain the trophine, this is what it'll look like down the microscope. Everything is in varying shades of pink, purple, and red, and I'll come to why that's important in a minute. We do add a few different stains to the trophine, so you'll often hear us talking about fibrosis in the bone marrow. So we look at fibrosis by doing a stain called reticulin staining, and this uses some silver particles to highlight these black fibers in the bone marrow, which are the reticulin fibers that are found throughout the bone marrow. And then sometimes we need to look at individual cells in more detail and pick them out from the background. So we can use another technique which will pick out certain cell types. So this stain here in brown is just staining the megakaryocytes, which make your platelets. And then we can use different stains to just pick out the cells which make red blood cells, or to just pick out the cells which make neutrophils. And this allows us to distinguish the cell types in a bit more detail. So what does the bone marrow actually look like? So if you imagine the bone marrow is a little bit like, a bone is a little bit like this honeycomb. When you look at pictures of bones in the body, what you're seeing is the hard surface on the outside. But if you cut into the bone, it's this meshwork of thin pieces of bone which interconnect together, very much like this honeycomb type appearance. So the thin pieces of bone here we call bony trabeculae, and then the bone marrow that we're really interested in sits in these spaces here in between the bony trabeculae. And as Andrew said, I've used exactly the same word, which is the bone marrow is a factory that makes the cellular components of the blood. And within the bone marrow, you've got cells that are very immature, so they've just formed, up to cells that are ready to be released into the circulation and to go round in the blood. So when we take a trophine biopsy, essentially we're seeing a snapshot in time with cells at every stage of maturation. And I've just highlighted this big round circle here because this is fat. And in fact, fat's quite important in the bone marrow. If you look at this picture of bone marrow here, you can see lots and lots of white circles, and this is lots and lots of fat within the bone marrow. And this one here has got a little bit less white circles, so a little bit less fat. And as everyone ages, the amount of active marrows, the amount of factory that's making cells that go into your blood reduces, and the amount of fat in your marrow increases. And this is really helpful for looking at whether a bone marrow is abnormal or not, because we often ask the question whether the bone marrow has got too many cells in it. And we can roughly work out whether a bone marrow has got the right number of cells, or too many cells, or too few cells by subtracting the patient's age from 100. So for example, in a 30-year-old patient, we would expect about 70% of the bone marrow to be made up of cells, whereas in a 50-year-old patient, we'd expect it to be 50, and in a 60-year-old patient, we'd expect only 40% of the bone marrow to be cells and the other 60% to be fat. So that if you ever see your bone marrow trophine reports and they talk about how cellular the bone marrow is, all we're doing is comparing the amount of active marrow with cells in it compared to the amount of fat in the bone marrow. And then another very important thing to consider in the bone marrow is this reticulin fibers and fibrosis. So often in myeloproliferative neoplasms, we might talk about whether the bone marrow has developed any fibrosis. And in your normal marrow, although Andrew said it's very liquid, you do need some scaffolding structure to support the marrow, and that's formed by these very fine reticulin fibers. So this is a normal marrow, and it's quite hard to see these very fine black fibers, but they are there. So in normal marrow, we just have a few reticulin fibers. But as your body, or in some patients, if you develop fibrosis in the bone marrow, you get more and more of these black fibers, and we pick them up using this stain. So you can see a few more here. You can see here we've got more black fibers, and what's starting to happen is the fibers are starting to crisscross with each other. And then in this bone marrow here, it's much more fibrotic. You can see many more of these black fibers which are crisscrossing together. And at the most advanced stage of fibrosis, you've got a lot of black fibers, not very many fat cells, and you can imagine not very much space for the bone marrow factory to be making red blood cells. So when we talk about fibrosis in the bone marrow, we're giving it a grade, and we're comparing it to normal, which is grade 0, which is not very many fibers, up to the highest grade, which is grade 3. So within the bone marrow, as well as the cells which make the components of your blood, there's cells which are making or removing bone. So we have cells like this. This is bone, this solid pink area here is bone, and we have cells along the edge of the bone that might be making new bone, and sometimes we have cells which are removing bone. And in myeloproliferative neoplasms, we'll often comment on whether the bone looks normal or whether there's new bone being formed. And new bone formation might happen in association with more fibrotic bone marrows. So this is a picture of the bone in your marrow. So these really solid pink areas are thin strands of bone, like we saw in the picture of the honeycomb. And this is normal bone in the marrow. And this is in a patient who's probably a little bit osteoporotic. So their bone has become a little bit thinned. And at the other extreme, the bone might become very thickened, and we term this osteosclerosis. And there's lots of new bone being formed. So when we're looking at the bone marrow, we look to see, is the bone normal? Is it looking thin? Or in the context of myeloproliferative neoplasms, particularly, is there new bone being formed? So all cells in the bone marrow have to start from stem cells, which can mature and form all the different types of cells that you see in the blood. But these very, very immature cells, stem cells or blasts, we often term them, are very infrequent. And we have to use special stains to pick them up. So this brown stain here is picking up these blast cells in a normal bone marrow. And normally we'd only see at most 2 to 3% of these small brown staining cells. And this is important because when we're checking whether there's any evidence of leukemia, what we're looking for are increased numbers of these blast cells. They're quite hard to pick up when they're so infrequent, but we can use this stain to highlight them. And we'll always give a percentage of how many blasts there are in the bone marrow. So one of the cell types that you'll often hear talk about is megakaryocytes. These are megakaryocytes. They're really big cells here. So these are all your cells here. And how do I know that it's a megakaryocyte? Firstly, I look at it, I can tell by its size. The next thing I look at is the shape of its nucleus. So this area in the middle of the cell is the cell nucleus. And you'll see that some cells have very, very round nuclei. And some cells, like this megakaryocyte, has a big nucleus, but it's got lots of lobes in it. And that's normal for a megakaryocyte. And megakaryocyte cytoplasm, so this pale pink area, not the nucleus, but the rest of the cell, is what makes platelets. And megakaryocytes, these big cells in the normal marrow, normally sit on their own. They're relatively infrequent, and they're scattered around. So this image here is just staining brown megakaryocytes, and you can see that these megakaryocytes don't really sit near each other. There's gaps in between them, and there's not that many of them. They're scattered throughout the bone marrow. So that's important to know about for when we're looking for abnormalities in myeloproliferative neoplasms, in which you might get increased numbers of megakaryocytes in the bone marrow, and they might start to cluster together. Another common cell type that we look at in the bone marrow are cells that give rise to red blood cells, and we call these erythrocytes. So unlike megakaryocytes, erythrocytes do like to sit near each other, and they tend to sit in clusters. So this is a cluster of erythrocytes, and I know that they're erythrocytes because they have very, very round, dark nuclei and quite reddish cytoplasm around the outside. And sometimes we use slightly different stains that pick them up a bit more easily. So in this stain here, they look quite purple. And again, you can see that they like sitting next to each other. And the other common cell type that we look for in the bone marrow are neutrophils or granulocytes, which eventually give rise to neutrophils. So again, I can recognize these by looking at the size of the cell. So they're smallish cells, looking at the nucleus, which, a bit like a megakaryocyte, has got lots of lobes. And then you can look in the cytoplasm, and you may or may not be able to convince yourself that there's some small granules. You might have spotted these cells here, which you can definitely see that there's granules in the cytoplasm, but these granules look very red. So these are cells that are going to become eosinophils. So when we're looking at the bone marrow, we're looking at the size of the cells from huge megakaryocytes down to smaller neutrophils. We're looking at the shape of the nucleus, and we're looking at the color of the staining. And this allows us to tell what they are. And if I want to be sure, I can do a different stain, which will pick out all of the granulocytes in brown here. So I can work out roughly how many they are and check that they are where they should be and that they're maturing properly to make neutrophils to fight infections. So what happens in myeloproliferative neoplasms is a couple of examples. So this was a 50-year-old female who was referred because they had an increased platelet count. And after the investigations that Andrew referred to, they had a blood test and they were found to have a JAK2 mutation. And this patient went on to have a bone marrow biopsy. And the question was, does the bone marrow biopsy look like essential thrombocythemia? So the first thing we look at is how cellular is the bone marrow. So this patient was 50, so we would expect their bone marrow to have about 50% cellular areas and 50% fat. So for this patient, it's about right. And that's what we expect for essential thrombocythemia. The bone marrow is normally has a normal cellularity, or it might be slightly more cellular than you'd expect. The next thing we look at is the megakaryocytes. So here on the left is our normal megakaryocyte, and in essential thrombocythemia, the megakaryocytes become large, and their nucleus, instead of having just a few lobes, has lots and lots of lobes. You can see all these round circles here. The nucleus tends to be quite a dark purple color, and you have many more megakaryocytes in the bone marrow than you would normally. We would then look at the rest of the bone marrow, for example, looking at the cells that make neutrophils, looking at the cells that make red blood cells, which we would expect to be normal in essential thrombocythemia. And normally at diagnosis, we don't see any fibrosis. So we can take all of those features together and come back to our colleagues in hematology and confirm that the bone marrow looks typical of essential thrombocythemia. What about in Polycythemia Vera? So again, a 40-year-old female who is presented because they're polycythemic, so they've got an elevated hemoglobin and they have a bone marrow biopsy. And this time the bone marrow is too cellular. So this patient's 40, so we would expect there to be about 60% cells and 40% fat, but in fact, there's a lot more cellular areas than that. So we say it's hypercellular, and then we have to ask, why is it hypercellular? What is there a particular cell type that's increased? But actually in Polycythemia Vera, what we see is it's all cell types are increased, and we refer to that as panmyelosis. Then we look at the megakaryocytes again, and you can see here, hopefully, that we've got some quite big megakaryocytes. Again, they've got lots of lobes in their nuclei. We've got some which are a little bit smaller. And typical feature of Polycythemia Vera is increased megakaryocytes. They start to cluster together. So you can see there's little groups of megakaryocytes, and they come in very variable shapes and sizes. We may or may not see reticulin fibers. So this is grade 1 fibrosis. You can see these black fibers here, which are starting to crisscross a little in the bone marrow. And we can use some stains if we want to highlight different cell types. So this is just picking out these groups of megakaryocytes and showing us that there's too many megakaryocytes in the bone marrow. And again, we put this all together and we say that in the context of a patient having an elevated hemoglobin and likely a JAK2 mutation, the appearances in the trophine biopsy would be consistent with Polycythemia Vera. Primary myelofibrosis in the prefibrotic stage, sometimes a little more difficult. A typical history might be a young patient who's presented with a very high platelet count, and their neutrophil count is also a little bit increased. And often the clinical question might be, have they got essential thrombocythemia? Again, we use the same approach and we look at the bone marrow. You can see that this bone marrow, again, is very cellular. So say this patient was about 30. In fact, most of the bone marrow is the purpley, pinky red cells, and very little of it is fat. And that would be quite unusual for essential thrombocythemia to have such a cellular bone marrow. Again, we look at the megakaryocyte. So here's our normal megakaryocyte. Here's a megakaryocyte typical of essential thrombocythemia. And in this bone marrow, the megakaryocytes are looking a little bit more like this. And you can see that they're quite big still, But this time their nucleus, instead of looking dark purple, is looking very pale white, and we often describe it as bulbous. And in the background, we've got lots and lots of neutrophils. So the typical picture of primary myelofibrosis, which is not yet in a fibrotic stage, would be increased cellularity, increased neutrophils and the cells that make neutrophils, and increased megakaryocytes, which look quite atypical. And by definition, because we're saying this is pre-fibrotic, we've only got up to grade 1 fibrosis. So again, our reticulin stain here with the fibers is showing these slightly crisscrossing fibers. Sorry. What happens when we get to myelofibrosis? Now, I've put here together primary myelofibrosis, post-ET myelofibrosis, and post-PV myelofibrosis, because in fact, when we look down the microscope, sometimes it can be quite hard once the bone marrow has become fibrotic to determine whether the original pathology or the original classification of myeloproliferative neoplasm was a primary myelofibrosis or essential thrombocythemia, which has become fibrotic, or polycythemia vera, which has become fibrotic. And this is an example where a patient had essential thrombocythemia and have very, very typical megakaryocytes of essential thrombocythemia. But some years later, their bone marrow became fibrotic. And by that point in time, their megakaryocytes looked typical of myelofibrosis. So often looking at the bone marrow once it's become fibrotic, it can be quite difficult to say what the original pathology was unless we've had a trophine biopsy at the time of diagnosis. Occasionally, the bone marrow becomes very, very fibrotic and they might get new bone formation. So this is when we see osteosclerosis. So here, it's the same as I showed you earlier. You can see these very thickened bits of bone. They're very irregular, funny shapes. And when we look at the bone marrow, okay, there's very little fat, but in fact, that's not because the marrow is very cellular. There's also relatively few cells. And the lack of fat and the lack of cells is because the bits in between are now fibrotic tissue. So it's not making hematopoietic cells, and it's likely at this point in time the patient won't have increased platelet count or increased hemoglobin. They will start to become anemic and their platelet count is likely to have dropped. So if you just compare this is normal marrow. You can see the other feature here is you can hopefully start to see that things are starting to line up. So we get this kind of effect of the cells streaming in lines because they're becoming trapped between fibers in the bone marrow. And if we stain it for reticulin, which picks up all these fibers, you can now see that most of the bone marrow is made up of fibrotic tissue. So all of this orangey brown staining is now fibrosis. And sometimes we add in some different colored stain, which just picks up, again, this fibrosis. So everything that is green here is fibrotic tissue. So when showing you these images, hopefully I've made it look relatively straightforward that we can make a diagnosis, but in practice, sometimes we have diagnostic dilemmas in pathology. I mentioned advanced myelofibrosis. So when we have a bone marrow trophine biopsy and it looks very fibrotic, it can be quite difficult to determine what the original diagnosis was. In some patients, particularly patients might present with a high platelet count and they might be found to have a JAK2 mutation, but their hemoglobin is normal. So clinically, they might be suspected to have essential thrombocythemia. And then we look down the microscope and the bone marrow looks more like Polycythemia Vera. At that point in time, we might question whether the patient's iron levels are normal. If a patient's iron levels are low, it might be that they're not making enough red blood cells to have the elevated hemoglobin typical of Polycythemia Vera. And this is often termed iron deficient Polycythemia Vera. Sometimes a diagnostic dilemma that we have in pathology is distinguishing essential thrombocythemia from pre-fibrotic primary myelofibrosis, and some of the features can overlap. And the difference between them can be quite subtle, and I sit down twice a week with my colleagues to review bone marrow trophines, and this is something that we commonly discuss between us about how best to classify the appearances down the bone marrow. Do we think it down the microscope, does it look more like essential thrombocythemia, or does it look more like pre-fibrotic primary myelofibrosis? Another situation in which we often debate diagnosis of myeloproliferative neoplasm is patients who have an elevated platelet count but don't have the JAK2, CALR or MPL mutation, and looking at the bone marrow trophine biopsy, deciding whether we think the changes are enough to say that this is essential thrombocythemia, or whether the changes are not diagnostic of myeloproliferative neoplasm, and in fact the elevated platelet count might be due to a number of other causes. And a small number of patients with Polycythemia Vera might have an alternative JAK2 mutation and JAK2 exon 12 mutation, which is not the same as the more common JAK2 mutation. And again, these patients' bone marrows can look slightly different from Polycythemia Vera. So as pathologists, it's really important that we have all of the information, for example, what mutation they have, to make sure that we don't miss diagnoses because the appearances down the microscope sorry, don't look entirely typical. So I've talked a lot about bone marrow trophine biopsies, but actually they're really only part of the diagnostic pathway. And the diagnosis of myeloproliferative neoplasms requires a holistic approach, taking into consideration the patient's clinical presentation, their blood count, what the blood film looks like, what the aspirate looks like, what the trophine looks like, whether they have an enlarged spleen, and what molecular findings there are. And as Andrew mentioned, we discuss these patients regularly at our multidisciplinary team meetings, where everybody involved sits down and we discuss all of the findings, and therefore we can hopefully make the best and most appropriate diagnosis. I've said any questions here, but please put any questions in the Q&A, and we're going to discuss those at the end. Thank you so much for listening.
Thank you, Anna. Those pictures are just amazing. So by now you should all be well clued up on what a bone marrow looks like and how current diagnostics work, and the type of processes that we go through to make a diagnosis. And I'm now going to hand over to Dan, who is, as I've mentioned already, is a haematopathologist at Oxford University Hospitals, who's going to give us a glimpse into the future. So we've looked at kind of what's now. Dan, what's coming up?
What a superb question. So I guess, yes, as Claire says, my name is Dan Royston, I'm a pathologist. Now, my children always laugh at me because I don't see patients, and therefore I'm not a proper doctor. And I boasted to them that I was going to see a lot of patients this afternoon, and here we are, I can't see you. Nonetheless, it's a pleasure to be able to talk this afternoon, and I'm very grateful for the invitation by MPN Voice to give my talk. Now, I hope you can see my slides.
Yes, we can.
And what I'm going to talk about a little bit is research, really, we've been doing in Oxford on myeloproliferative neoplasms. And for many years, pathologists have worked very closely with haematologists on research, and also in terms of delivering clinical practice and supporting patients with myeloid disorders. What's quite exciting in the last few years is that we've begun to form collaborations with other scientists whom in the past we've not worked particularly closely with. And in Oxford, we've worked very closely in recent years with a group of biomedical engineers who are very interested in applying artificial intelligence and machine learning to certain problems in medicine, particularly problems around image analysis. As both Andrew and Anna have touched on very nicely, and the diagnosis of a myeloproliferative neoplasm is really a combination of features. We have the appearances of the bone marrow, we have the results of molecular genetic tests, we have routine blood tests, and of course there's the clinical presenting features as well when patients come to clinic. Now, in recent years, there's been an explosion in our knowledge of the genetics and mutations that are responsible for bringing about or causing myeloproliferative neoplasms and actually driving their progression in some patients who unfortunately have progressive disease. By contrast, the features of the microscope of bone marrow trophines and aspirates hasn't really changed an awful lot. There have been some refinements and improvements, but we've been doing the same thing for quite a few years. What's clear, though, is that in order to really improve our diagnosis and patient management, there's a real opportunity to try and improve and enhance these microscopic features in a way that can inform and improve the result of genetic tests. And in particular, there is a recognized need to improve the early diagnosis of MPNs, but also improve our accuracy in making a diagnosis, making sure we're not overcalling or undercalling our MPN diagnoses. And also we need to move away, if possible, from descriptions of features into more precise measurements that give a better understanding of what's going on in the marrow, and also allow us to correlate these features to the genetic tests and the new mutations that we're finding. And this is another example of a bone marrow atrophy that Anne has gone through in very nice detail. And what Andrew and Anna probably haven't touched upon too much is that in order to get to a position where you can review a bone marrow and you can identify all the relevant features and combine them into a bottom line diagnosis, takes years of practice and requires a lot of skill. And in the end, we have to find a way of compressing all these features into a text report that's then issued to our clinicians and sometimes even read by our patients. And this can be very, very challenging and particularly hard to incorporate all these features into this report. What we therefore have done in Oxford in recent years is think about what are the features that Anna has touched upon in the diagnosis that we can identify in a more reliable and robust way that doesn't require pathologists like me, Anna and Andrew, to spend time looking at with colleagues who are perhaps less experienced. And what we've done here is we've scanned a large collection of patients' bone marrow atrophy into a computer, and using annotation that is drawing around individual structures, slowly and gradually train a computer to spot these cells of interest. And this is a high-power image of a scanned bone marrow atrophy where we've got some megakaryocytes that are bounded by green boxes. And that is the computer saying, I think this is a megakaryocyte, do you agree? And that contrasts to what's in the red box, which is a structure in the bone marrow which looks a little bit like a megakaryocyte but isn't. And using this kind of machine learning computer model, pathologists can make decisions, say, yes, that's a megakaryocyte, or that's not. And slowly and gradually we can build a model to make more accurate predictions. What we did was we looked at around 150 to 200 bone marrow atrophies in patients with either a diagnosis of myeloproliferative neoplasm or with reactive marrows. And we were able to extract several thousand megakaryocytes from all these marrows. And using this computer, what we could do is we could group all these cells into clusters of cells that all looked a bit similar. And what we found was that we could take all the megakaryocytes and roughly divide them into 9 groups, 9 cell types. So in group 9 at the bottom, we've got quite large atypical megakaryocytes, which are very typical of a myeloproliferative neoplasm diagnosis. And in groups 1 and 2, we've got megakaryocytes which are quite small and look fairly normal. What's interesting is that between those extremes, or very normal looking and very abnormal, there are different grades of cytological features or features in the megakaryocytes, which are very, very hard to spot reliably, but a computer can do it and can do it very reliably. So having identified these different types of cells in all these samples, what we were then able to do was to go back to the original individual patient trophines and look to see each of the megakaryocytes, what group do they belong to that the machine has identified. And here's an example of one of these bone marrow trophines, and every single megakaryocyte has been replaced by a circle. And the color of the circle corresponds to which of these 9 groups the computer thinks belongs. When we do this, what we notice is that when we compare a normal or reactive bone marrow to one with a myeloproliferative neoplasm, the pattern or distribution of these megakaryocytes changes. The proportion of cells which belong to group 9 or 8 are increased in an MPN, and the proportion that belong to group 1 or 2 are typically dominant in reactive marrow. What we could then do is say, well, in addition to which type of megakaryocyte it is, do these cells sit on their own? As Anna said earlier on, normal megakaryocytes typically are solitary little creatures sitting in the bone marrow, surrounded by other cell populations, whereas in myeloproliferative neoplasms, they often cluster. So we can look at whether these cells, they cluster, how close are they to the bone and to other structures, which may be a sign that they're abnormal. When we take all those features of what type of cell it is, what group it belongs to, where it sits in the marrow, how it clusters, we can then think about how to capture all these features from all these patients in one go, so we can look at the disease and ask questions about what are the important features. So those slides look a little bit complicated. It's really quite simple. Both these figures, these graphs are basically the same. And in the gray area here, we have all the megakaryocytes from patients who have got a normal reactive bone marrow. In blue, we've got all the megakaryocytes that belong to patients who have been diagnosed with Polycythemia Vera. In yellow, these are patients who have essential thrombocythemia. And in green are patients who have got myelofibrosis. What we can then do is, having looked at a library or a collection of patients, several hundred patients who've been diagnosed with each of these MPN subtypes or reactive marrow, we can then ask the question for an individual patient who we're now looking to investigate, whereabouts do the cells in that patient's bone marrow sit when we look across this library of samples. And on the left-hand side, we've got two patients who have had, in red here, we've got a patient who's had 5 bone marrow trephines. Yep, 5, that sounds painful, spanning around 5 years. And what we noticed was, even though this patient has got a diagnosis of Polycythemia Vera, which overlaps a little bit with myelofibrosis based upon this figure, this patient has had a stable disease, and the features of the megakaryocytes haven't really changed with time. They're very, very consistent. And that implies that the morphological features or the appearances in the marrow aren't changing, and that doesn't correspond to disease progression. In blue, we have a patient who's diagnosed with essential thrombocythemia, and similarly, the 2 biopsies taken 2 years apart contain cells that look very, very similar. And indeed, these features correspond to very little evidence of change in the mutation in these patients, or indeed the blood counts. On the right, by contrast, we have the same background figure showing reactive in each of the MPN subtypes, but we have 2 patients who unfortunately showed evidence of disease progression. The patient in green here, represented by the circle, was diagnosed with Polycythemia Vera, and 4 years later showed evidence of worsening symptoms, an enlarging spleen, and an increase in the mutation of the driving mutation. I think it was a JAK2 mutation. And what we can see is that this corresponds to a shift or a change in the appearances of the megakaryocytes in the bone marrow that the computer can spot, detect, and demonstrate this movement across this so-called disease space. And here in blue, we have a patient who's diagnosed with essential thrombocythemia, who similarly showed evidence of progression of the disease to a more fibrotic marrow with an enlarging spleen, and again, an increasing mutation burden. And again, we can see that the features of the megakaryocytes moved from a very typical ET space into a more abnormal and myelofibrotic space. And what's nice is that rather than us writing a report and describing the first marrow using language like atypia or large cells, small cells, and then trying to work out what the difference is between 2 written reports, this way you can actually visualize, you can see the changes using this graph without any expertise on how to report a trephine. And I think that's useful for pathologists who are perhaps not so experienced at reporting bone marrows, but also for clinicians and potentially also for patients who might want to understand how their features in the bone marrow are changing. Another feature that's been touched upon by Anna very nicely is the importance of bone marrow fibrosis, that is the presence of abnormal fibers of reticulin and collagen in the marrow, which typically is seen in advanced MPN cases and sometimes with disease progression. Rather like megakaryocytes, one of the difficulties is that we have to use a so-called grading scheme of 4 individual grades from grade 0 to grade 3. And although we have a definition for this, it can be very, very hard to apply to individual patient samples. And we also have the problem that the stains we've seen so far today have been beautiful sections. Sometimes the stains we get from the samples are not so good, or the samples themselves are a little bit broken up and therefore hard to interpret. And as Anna's already shown, this is an example of a bone marrow trephine with very little evidence of fibrosis. So these black linear fibers correspond to minimal fibrosis. And by contrast here, we have a bone marrow with far more fibers that are a little bit thicker, and they're beginning to form bundles or cords that begin to course through the marrow. Here's an example of the real world problem of reporting bone marrow trophines, in that this trophine is a little bit broken up. And so we've got fragments or shards of bone. We've got some intact intertrabecular spaced area between the bone that's responsible for blood formation or hematopoiesis. And then we've got some blood. So for a pathologist, it can be very hard to work out, well, what is the fibrosis grade here? That area has quite severe fibrosis. This area is less severe fibrosis. So what grade do we call it? How do we capture that information in a report, which is going to be useful to allow us to track or monitor changes in a patient's disease? So again, to try and improve this, we went back to our machine learning approaches and our collaborators in biomedical engineering, and we took some bone marrow trophine images and we manually drew around areas that we thought corresponded to more severe or less severe areas of fibrosis. And using multiple rounds of training, we began to train the computer to spot areas of fibrosis and estimate how severe the fibrosis is. And the result is this. This is an image of a routine real-world bone marrow trophine, which is stained with this reticulin stain, which gives the dark linear fibers of the reticulin. And rather than having the black image, what we can do is, using the image analysis tool that we've designed, we can begin to find areas and look for differences in fibrosis. So here we've got a color map or a heat map, which shows the variation in the fibrosis across the marrow. So in blue, we have areas of the marrow which are normal or near normal with very little evidence of fibrosis. By contrast, in red, we've got areas of more severe fibrosis. And what you can see across the marrow is that in areas like this, you've got quite advanced fibrosis that probably amounts to kind of grade 2 or grade 3, although in some areas a little bit crushed. We've got to be careful how we grade that. And elsewhere, at the other end of the marrow, we've got relatively normal looking bone marrow with no evidence of fibrosis. And these boxes here that are colored correspond to these boxes at the bottom, where we can see actually quite correctly the machine is identifying that there's increased fibrosis in A with little evidence of fibrosis in box E. So really, that's a very, very brief summary of the kind of features that we're beginning to tease apart in the bone marrow. And although megakaryocytes and fibrosis are only two of the features that we use to diagnose myeloproliferative neoplasms and to look for change in disease, they are very important. There are other features that we're beginning to look at as well, but that will take some time to develop and to build. And so my view is that in the future, what we should be able to do is to look at the bone marrow trophine biopsies and begin to build up a multi-layered approach where we can look at the individual structures in the bone marrow and address a number of questions. So at one level, we should be able to summarize all the features and give a refined diagnosis, which is accurate, consistent, and doesn't get significantly affected by variations in the laboratory or the pathologist reporting the bone marrow. We can also use these approaches to look at small areas of the marrow and ask questions about, well, what's happening in patients who do develop more aggressive disease? Where does it start? What are the features in the bone marrow that might be a clue to disease progression or to response to therapy? And then at the very kind of high resolution end, we can also ask questions about very specific single cells. And this, I think, has real potential for the evaluation of novel therapeutics, which are targeted towards individual cell populations. But in the end, I think, as a pathologist, what I'd like to see is us moving away from these text-based reports to a representation or a visualization of patient samples that can be understood by everybody, by pathologists, by clinicians, and patients, that give a very intuitive understanding of what's going on in the bone marrow and how it's changing with time. I'll finish there. I just wanted to say at the end a really significant thank you to all our patients and their families whose support is essential for this kind of research. Any research on myeloproliferative neoplasms is dependent upon the willing submission of material with consent to allow us to conduct the research. And also, it's fantastic to have patient advocates supporting our research and willing to encourage this kind of work. And sometimes as pathologists, because we don't see patients very often, it's a little bit hard for us to communicate directly to patients. So I'm really pleased we've had this chance to present some of our work this afternoon, and I hope that's been useful. So thank you very much for your time.
Well done, that's fantastic. I'm sorry that we're disappointing your children by not having a sea of faces of patients that are here, but I know that everyone who has been here today and will hopefully have the opportunity to see this webinar as well online afterwards will really appreciate your presentations. So now we're going to move to the question and answer session, and I don't want to be the only person with my camera on. Thank you, Anna. So maybe Dan and Andrew. Yeah, great. Oh, the lady behind you's gone home, has she?
Yeah, went to pick up the kids.
Okay. Perfect. So absolutely fantastic presentations. I really enjoyed that. And I know that our audience did as well. So we're going to start with a kind of interactive question and answer session that's going to go on now for about 25 minutes. Some of you have submitted questions already. Some of you have been putting questions in the Q&A function on Zoom, and do please feel free to keep putting them in. If we can't answer them now, we will try to answer them later. So I'm going to jump in perhaps with a question for that, well, any of you might want to comment on, but maybe you, particularly Dan, because you raised this question, which is about how do we know now if bone marrows are correctly reported? Because you raised some comments, and we could see some of those pictures of trophine biopsies that were a bit broken, and unfortunately sometimes that does happen. So any comments about sort of accuracy now in the real world before we have?
Yeah, I think that's a really important question, a real difficult question. And so Andrew, Anna and I are specialists, and we specialize in hematopathology, and we look at bone marrow trophines all the time. I think it's certainly true even amongst very experienced people. There is often disagreement about what the relevant features are. And we do occasionally have some discordance or disagreement about how best to classify or describe some of the features. As both Andrew and Anna said, that's why I think it's very important that when we do report our bone marrow trophines, the report doesn't stand alone. It has to be contextualized to other features. And the MDT, or the consensus meeting, of course, is a really important opportunity to ask questions about the bone marrow trophine features and really make sure that everything fits together. But to answer your question directly, I think it is a challenge, and there is evidence in the literature about this issue of discordance. And certainly for fibrosis, I think at the extremes of fibrosis, it can be quite hard to get an accurate grade. And I think that's really why we do need to think about ways of improving and refining our measurements of these features.
Yeah. Or Andrew, did you want to also comment on that?
Yeah, I think I agree. I think we have lots of discussions about these difficult cases. We discuss it in the MDT, and often I go back to patients and say, look, actually, we're not quite sure whether it fits in that box or that box, but actually this is how we're going to take things forward, and we'll monitor things closely. And we may want to repeat the bone marrow in a few years' time, or we make a plan going forward. So sometimes I don't know. I think my patients sometimes appreciate that sometimes we can't give them an exact answer at that time, but we're working really hard to try and do that.
Yeah. I mean, Anna, we sometimes talk about, the thing is that the classification system which we use, comes from the World Health Organization, sometimes very rigid, isn't it?
Yeah, that was just what I was going to. I mean, we're kind of, because we follow this classification, we're trying to put everything into essentially 3 boxes, but in real life it doesn't really work, and we've got a spectrum running between all of the kind of Polycythemia Vera, ET, primary myelofibrosis, and yeah, I think, and sometimes one biopsy looks quite typical of one thing, and then a further biopsy might look different, and we might revise the diagnosis, and that doesn't necessarily mean someone somewhere got it wrong the first time. It just sometimes is very difficult to apply the terminology.
There is this diagnosis called MPN unclassified or not otherwise specified, isn't there? So there actually, even the World Health Organization recognizes that it can be difficult. And I suppose the other thing is increasingly we do sometimes pick up, for example, a JAK2 mutation in a patient that's got a normal blood count. And so sometimes we do a bone marrow to look for an MPN, and sometimes there aren't signs of that there. I don't know whether, Andrew, you might want to comment on that, or do you see much of that in Newcastle?
Yeah, we do get that where people have had the JAK2 test done because of a certain reason. Maybe they've had a particularly severe blood clot, and they have the test done and it's positive, but surprisingly their blood count is completely normal. And sometimes we look at the bone marrow at that time point, and the bone marrow may look very subtle, or it may not give us a direct answer. So in my practice, generally we just monitor these patients quite closely. We keep an eye on their blood counts. We look at the blood film under the microscope, and then we may repeat the bone marrow if something's changing. And that's someone that, you know, I may decide not to do a bone marrow on if it's not going to change exactly what I do at that time point. Some people are very nervous about having these tests done, so I try to see what the patient wants, and some people are fine not knowing the exact WHO classification of their disease, and some people want to know all the information. So I kind of sometimes take the lead from the patients, and often if they've had a blood clot, they're on blood thinning medications, and sometimes to do a bone marrow safely, they may need to come off those blood thinning medications, which may be risky. So there's lots of things to weigh up.
Okay. And actually, there is this thing called CHIP, isn't there, where you can actually have a low level of a mutation like JAK2 and have a completely normal blood count. And there is some evidence that you can be at increased risk of blood clots. And not all patients with that do go on and develop MPN. I don't know whether Dan or Anna, you want to talk about that at all, or we can move on to another question. Move on.
Yeah.
Okay, so I'm going to ask you guys, what's the significance of reticulin versus collagen fibrosis? I don't know which of you might want to answer that one first.
Shall I go, Anna? Okay. Yes, it's a very good question, actually. I didn't touch upon very much the difference between collagen and reticulin. So reticulin, as Anna mentioned, is a normal component of the marrow and provides a scaffold for hematopoiesis. So it's abnormally accumulated in MPN. In the more extreme, at the more extreme stage of fibrosis, we begin to see collagen deposition, which is typically seen in the grade 2 and grade 3 categories of fibrosis. And that really represents a very extreme end of fibrosis deposition in the bone marrow. So collagen and reticulin are very similar in terms of their components, but reticulin is a normal feature which is abnormally increased. And at the extreme end, we begin to see collagen deposition. And we use collagen deposition as a clue to the more advanced grade as specified by the WHO.
Okay, very helpful. Thank you very much for that. Now, Andrew, I wanted to ask you a question that's come from Andrea Kirchnopf. Sorry if I pronounced your name wrong, Andrea, but you asked a really important question about iron deficiency. And Andrew, you pointed out quite a lot of issues with pitfalls, and there's a few that we thought would be good to discuss. You talked about MCV and people having loads of investigations for it when it might be due to the hydroxycarbamide. So I'm going to read out this question. How do you remedy iron deficiency in an ET/PV patient who cannot take any iron supplements? Are there any other blood values or functions that make up for iron deficiency? So maybe the first question is about, is it safe to take iron supplements, and then wrap up with any other comments that you have?
So I think it's probably important just to go one step back in that iron is a really important fuel for the bone marrow. The bone marrow needs iron to make the red cells. But in people with polycythemia, where the bone marrow is making too many red cells, one of the things we do as doctors to try and stop the bone marrow from making too many red cells is to restrict that fuel. So we try to make people iron deficient, and we can do that by venesection, by taking a pint of blood off. So one of the things that we do with some patients is we'll take some blood off with the aim of removing some of the red cells, but also removing some of the iron to prevent the bone marrow from going into overdrive. So, but when we do that, although that helps with bring the red cells down, that makes people iron deficient, and people can get other symptoms relating to iron deficiency. And that's when things do become a little bit difficult, because we don't want to give them iron replacement, because then that will just undo all of the good work that we've just done, spending weeks on the day unit doing the venesections, only to give some iron, and then it's undone, and often undone quite quickly. So sometimes in that situation, if people have lots of symptoms relating to iron deficiency, we sometimes change them onto something else like hydroxycarbamide, and the hydroxycarbamide can reduce the blood counts, and that means that we can sometimes quite cautiously replace the iron to a degree where the patient's symptoms are a lot better. So so it depends on how bad the symptoms are, really. Sometimes we can replace iron in people with PV, but I wouldn't do it without review from your haematologist. With ET, I think iron replacement is often okay. So I'm quite happy to give iron replacement for people with ET if they've got iron deficiency. And sometimes iron deficiency can cause the platelets to go up. So sometimes that's what we do in the clinic, and that can bring the platelet count down. So I hope I've vaguely answered that question. But it is important, if you're taking a multivitamin, that if you're being venesected, then not to take one with iron in, because you're probably undoing some of that work that the venesection is doing. So it's important, if you are taking something over the counter, to try and avoid something with iron if you've been told you shouldn't take iron. So that's probably something to consult with your consultant, really, to make sure you're one of these patients that maybe should or shouldn't take any iron supplements. And unfortunately, if you need iron, then iron is the only thing that's going to correct that. You can't take something else in substitution for iron. So it does become a bit difficult in those situations.
Okay, that's absolutely lovely. So one of the pre-submitted questions was about transformation, about ET transforming. Is it more common for ET to transform to PV or to myelofibrosis? And there is a comment in the chat from anonymous attendee who says, I had a bone marrow biopsy and was diagnosed with ET with a JAK2 mutation. A year later, I was re-diagnosed with PV and had another bone marrow biopsy and told I had PV from the outset. How was I misdiagnosed? Well, I think we can't really answer about how were you misdiagnosed, because you might not have been, because it's possible that your ET could have become PV. But I wondered, Anna, did you want to, or somebody else, touch on this idea of these diseases changing from one to the other, which actually was part of the original description of MPNs, that they are conditions where there's actually a lot of overlap. And even down on your images, we could see that, couldn't we? The images of the megakaryocytes, we could see overlapping between all of them. Anybody want to comment on this issue? Anna, maybe?
Happy to comment. I mean, I think we know that, we've mentioned that there is a bit of a spectrum, and things, although if you look when we look in the textbooks, it looks very clear cut, like ET looks like this, PV looks like that. But actually, when we look down the microscope, sometimes it's not always as clear cut, and we might have a bone marrow that looks quite like ET, but there's some atypical features, like it might be a bit more cellular than you would expect, or the megakaryocytes might look not quite like ET. And as I mentioned, occasionally patients might be diagnosed with ET, but actually at the time they may have been iron deficient. So later on, when their iron is replaced, the disease might declare itself as being more like PV. So there's a number of reasons why the disease classification might change over the time. It may be genuinely that the disease itself has changed slightly, or it might be other factors influencing how it's presented and why those blood counts are elevated or not elevated. So yeah, I think there was another question about change. So I didn't catch the first question, was about transforming from ET to PV or ET to myelofibrosis. Is that?
Yes, it was about which is more common.
So transformation of ET to myelofibrosis is relatively rare, but potentially PV and ET can both progress to myelofibrosis in the same way that primary myelofibrosis might initially, although the name suggests it's fibrosis, it might initially not have fibrosis in the bone marrow. So they may all become fibrotic, but the risks are different with the different diseases, and least likely with essential thrombocythemia.
If I could just make one additional comment as well about biopsies, of course, we need to consider that the trephine we take is a very, very small amount of the total bone marrow, and it's perfectly possible that you see variation across the bone marrow of patients. And depending upon where the biopsy is taken and what part of the marrow is sampled, you can get a slightly misleading impression based upon the first biopsy. So it can take 1 or 2 biopsies to properly evaluate all the relevant morphological features. So in addition to the fact that we do see genuine progression of disease with time as well. So you have the added complication.
I think we see, like Andrew and Dan, we see so many of these biopsies, and we often go back and look at previous reports. And it's not uncommon that over time you might see there's been slight variations in the diagnosis or the terminology used over time. Some of that's, like Dan says, looking at different bits of the marrow. Some of that's slightly different opinions between pathologists. So there's a number of reasons.
Sometimes it can be just actually one of the things we think is part of the reason why ET presents in one way and PV presents with what Andrew, you described as what pan-myelosis, you use that term as well, Anna, which means increase in all blood cells, not just platelets. And that's to do with the amount of JAK2 that there is to some extent, as well as where the mutation actually happens. So it could be that over time, chromosome 9 has changed a little bit. Chromosome 9 is where the JAK2 gene is. And there could have been a stepped increase in the amount of JAK2, which means that there's more red cell production, for example. There is a question in the chat, which might put to everybody, which has come from Maria Vahavuo. So Maria's asking, she's asked a couple of questions actually, so thanks for that. But your first question is, just a few weeks ago, I've been diagnosed with PV. So we're really glad that you've made it into this meeting so you can find out a bit more about it. I'm living an active, sporty life with frequent venous sections and no medication. A bone marrow biopsy has not been taken. So first question is it necessary to do a biopsy to make a diagnosis? And then the second one, so I added the first one. The second one is, what are the disadvantages of not having a biopsy or not getting to know about fibrosis until some symptoms arise? I think it's a good question because we don't always do a bone marrow. Andrew, you've touched on that, haven't you?
Yeah, I mean, I think that in my personal practice, and some people may do things differently, that I think in this sort of scenario, when I have patients with a high hemoglobin, they've got the JAK2 mutation, and I've looked at various different sort of aspects of how they've presented in their symptoms and their examination. I'm quite happy that that sounds like Polycythemia Vera, and there's quite a dictated management plan. You either do venesection or hydroxycarbamide or another medication. So I think in that case, I wouldn't generally offer a bone marrow biopsy. I think sometimes it's people, there's a few people have commented in the chat saying about a baseline bone marrow, but actually the risk of transformation to myelofibrosis is actually still quite small. So I would be worried that I would be subjecting far more patients to having bone marrow biopsies than they need. And if we need to do them, we need to do them. But for those of you that have had them, they often aren't the most pleasant procedure to have done. So I think if I think it's needed, then I will do them. But I think I've always got to think, what are the complications of having one done? And therefore, I think in that sort of situation, I'm quite relaxed about not doing a bone marrow. I don't know whether you think anything different, Claire.
Yeah, I haven't had a bone marrow myself. I've done lots. I think it's not strictly necessary, exactly as you said. And so my conversation would go similar to yours, but I would sometimes encourage a patient to have a biopsy so that we've got a picture of how the disease is at the moment. I don't think the biopsy itself is going to tell us a lot about risk of progression to fibrosis, unless there are unusual features there, like unexpectedly high grade of fibrosis, but there are other ways that you might pick that up. I don't know about Dan or Anna, what you think about that. See, we're expressing a spectrum of opinion here, which is exactly how real life is. It's not about the square boxes and the round boxes.
I was going to say that's interesting, because even in recent years in Oxford, Claire, the practice of sampling patients with PV has changed, and it seems to be partially informed by preferences between the consultant team. In fact, there's variation in that threshold for taking a trophine, and it's not always completely evidence-based, is it? There is that variation, and in research centres like Oxford, I'm sure you're the same, there are individuals who are interested in myeloproliferative neoplasms whose thresholds are a little bit different.
So there is another, yeah, exactly. And I don't think there's anything wrong or right about that. But I think if there was a lot of fibre in the bone marrow, what I would say is we would probably see some other signs of that. So we might see some changes in the blood film. So sometimes the red cells become a bit misshapen, and we see some early, blood cells that are released a bit earlier. And there's also a blood test that we do quite often called LDH. In fact, there's a question about that was submitted, I think, which we tend to do at Guy's anyway, once or twice a year on most of our patients, just as a way of monitoring. So if any of those things were unusual, or the white count was unusually high, or platelet count unusually low, or the spleen a bit bigger, then we would go and do a bone marrow, I think. Of course, only if the patient agreed, because ultimately we want to wait to diagnosis without looking at the bone marrow, because it's painful, isn't it? And it's a bit variable. So there's a question here about grade of fibrosis correlating with prognosis. Somebody want to comment on that, maybe?
I can, if you wish.
Dan,
Anna,
yeah, great.
Anna, would you like to go? So I'm talking too much, Anna.
No, nobody's talking too much. Go ahead, Dan.
Yeah, it's good to say. So we know also that within the classification scheme, the grading is also part of the diagnosis. So, for example, essential thrombocythemia, while we can see grade 1 fibrosis, if you see more than grade 1 fibrosis, that probably, although possible, is less likely to represent essential thrombocythemia. So another MPN diagnosis should be considered. It's also known that advancing fibrosis in Polycythemia Vera is often an indication of an inferior prognosis. And the same is true also of myelofibrosis. Advancing more severe replacement, extensive replacement of the marrow often correlates, I think, to the mutation profile and also the peripheral counts and the presence of splenomegaly. So it does have prognostic significance for some of the MPN subtypes. It's particularly important for distinguishing ET from early myelofibrosis. And so the grading really is important.
Yeah, there is actually one prognostic scoring system that we use, and there are lots in myelofibrosis, which does use grade of fibrosis. But there are lots of other things that we take into account. So I had a couple of questions. So there are loads of questions in the chat and we're running out of time. I'm loving the fact that everyone is so interactive. A couple of questions about bone marrows again. There was a mention of fat in the bone marrow. Is that healthy fat or unhealthy fat? And is it due to obesity? Should we worry about that? Anna?
Okay. It's normal. So everybody has fat in their bone marrow, and it plays an important role. There's kind of chemical interactions with the fat. It helps the cells in the bone marrow survive. And just over time, as you get older, you make less blood cells, and the areas that had blood cells in get fat, but it's not related to obesity and it's completely normal. So some fat in some areas of the body are normal.
Okay, good, great. And then Andrew, you talked about pitfalls, and I think there's a few other pitfalls that are important to mention. And we will try to send some answers to some of the other questions we haven't had a chance to answer today. But can I ask you a couple of things? First of all, about whether blood results can differ between different labs.
Yes, they can. So some labs will have different normal ranges. So generally what we do is often the lab will create a normal range for their normal population. So that may change slightly. Some labs will use different reagents, and the different reagent or the different machine may produce a slightly different result. So that's why labs may change between if you go from one hospital to another. Usually not significantly, but it may change a bit. And also if one lab is very far away and your blood has taken a little while to analyze, that can change, particularly in the summer if blood tests, blood tubes stay in the back of hot vans for the whole afternoon. Sometimes that can change, particularly the size of the red cells. It can change depending on how long it takes to reach the analyzer. So yes, so blood tests can change slightly depending on timing and depending on the lab.
Now, another common problem that my patients have is they get rung up to say they've got a high potassium. And I think that's something that's really quite important to talk about today.
Yes.
To save patients being shipped to A&E in the middle of the night because of a very high potassium.
Exactly. So my clinic is on a Thursday afternoon. So that means that the blood tests, the biochemistry blood tests often don't get the lab until late on. And then, so I unless I really need to, I try to not test the potassium for that reason. And for the patients, that the reason that this is a problem is that the people with high platelets, the potassium is in the platelets, and when the blood is in the test tube, the potassium will leak out of the platelets, and then when eventually the tube reaches the lab, it looks like there's a high potassium, and the potassium is a type of salt that's in the blood. It's normal to have potassium in the blood. But in people, particularly with a high platelet count, the potassium can leak out and cause a high result inside the test tube. It's not a high result inside the patient, it's just a high result inside the test tube. And then often, as Claire says, people come to A&E and then it's retested and sent to the lab immediately, and it's completely normal. So I tolerate, if I do check potassium and it's slightly elevated, I'm quite happy that that's due to the platelet problem rather than the potassium problem.
Excellent, because that can cause a lot of stress. I bet it does with your clinic on a Thursday. Mine's on a Monday and a Tuesday, so it's a little bit easier. So there's lots of questions here, and I'm going to round up by asking a question about fibrosis and fibrosis progression. And any of you can chip in. So there are a few questions. One, does everybody progress? Two, what are the mechanisms of progression? And two, does that particularly relate to mutation? So there's one question that's come in from Angela Hall about I have a CALR type 2 mutation. How does this relate to reticulin in the bone marrow? So maybe let's start with, does everyone progress, and is it related to mutations? Anyone want to talk about that? If not, you can volunteer me and I'll talk. I like talking. According to my children, anyway.
So I think one of the answers to that is that not everyone will progress. No, actually, it's the minority of patients that will progress. So although I do tell people that there is a risk of this, I try not to dwell on it too much because I think it is a minority of patients.
Exactly. And mechanisms of progression as well are very complicated. They're not particularly linked to the type of mutation, although there are some subtle differences. Angela, particularly with regard to your question, it doesn't mean that you've got myelofibrosis. You could have ET with that mutation as well. And there's also a question about, does treatment increase the risk of disease progression? So actually with our current modern treatments, we don't think that that is the case. And in fact, there is some suggestion that some treatments might reduce the risk of progression to fibrosis, but that's not usually a reason why we would start a treatment, is it, Andrew?
No.
Good. Anybody else want to comment on that? Because I could see a lot of questions about progression to fibrosis. No. Then a last one about, is there any blood tests that can be used to pick up fibrosis? Will we be using blood tests, not bone marrows and images on the bone marrows in the future? Anyone want to talk about that?
I guess I can mention what so in the blood tests, if people are developing more fibrosis, sometimes the platelet count, which may have once been high, might start to fall. People's spleens can sometimes be enlarged, and also when we look at the blood under the microscope, as you've seen from some of the pictures, the red cells, instead of being round, they end up being this teardrop shape, and we start to see some other cells in the blood, on the blood film as well. Some of the neutrophils change slightly as well. So there are lots of signs that we can see by just looking at the blood under the microscope before we have to jump to do a bone marrow.
We don't do a blood film all the time, do we? Because sometimes sometimes our analyzers, which look at tens and tens of thousands of cells, are actually better than us mere mortals. So it's coming back to Dan's theme, isn't it? That the blood count analyzers can actually pick up abnormalities in the blood film, can't they? They can pick up early red blood cells, etc. So we don't always look at a film. And
I think for the patients as well, when a blood test comes through the lab, our scientists will look at the numbers. They'll often look at the blood film under the microscope, and then they'll only pass a minority onto us. So if I see a patient, I will certainly look at it in a new patient, and I will look at it if someone I'm worried or something's changing, but I certainly won't look at every single patient's blood film, because I would probably be here all night if I did that.
Home to your family. Also, the analyzer is looks at more cells than we do, doesn't it? Anyway, I'm keeping everybody here on a very nice here Friday afternoon. So I want to just thank all of you for giving such a fantastic insight into the laboratory aspects of haematology, which is, I agree with you, Andrew, actually, it's one of the massive draws of this discipline. And thanks to Anna for showing us the trophines and what they look like. And Dan, thank you for giving us a glimpse into the future. And I think we probably put a call out for some patients to support patient kind of input into your work and the work that you're planning to do going forward as well. Is that right?
Thank you. Yes. Yep. That would be fantastic.
Yeah. So we'll see a call for that. Before I hand over to Nona, I just want to say thank you all for submitting loads of questions. I'm really sorry we didn't get to all of them. We will try to collate them and put some responses out on the website. So thanks to everyone. Nona, over to you.
Well, what can I say but a huge thank you for the most amazing forum. There's been something for everyone, and certainly I've sat here learning so much about what goes on in the background from point of diagnosis to point of ongoing treatment. But on behalf of all of us at MPN Voice, sorry, I'm still croaking with the COVID thing. I would like to say a big thank you to everyone in our community for your ongoing support. But I do want to give a special mention to all the clinicians who so generously give up their free time to support the forum. It really is appreciated by each and every one of us. Many heartfelt thanks to all of you for all that you are doing to help the MPN community. And that's not also forgetting Danny Palmer at the Commercial Service Directorate at Guy's and St Thomas's Foundation. We couldn't do these virtual forums without you, Danny, and it's amazing the support that you give us. So a big thank you from the MPN community. We look forward to seeing you again soon. Hopefully some of you watching this will come to Cork on the 21st of May. Maz has been WhatsApping me, telling me we've had some people joining during the process of this joining and booking on during the process of this forum. But we do look forward to seeing you all soon. And the main message is stay well and keep safe. And thank you, thank you, thank you.
Lovely. Have a great weekend, everyone.